Hello, this is Margie Meady, and I'm recording the Suicide Prevention PowerPoint for Psychiatric Mental Health Nursing. It's important to realize that suicide is not a diagnosis or a disorder, it is actually a behavior. More than 90% of suicides are by individuals who do have a diagnosed mental disorder, but it is not a disorder in and of itself, it is a behavior. This slide just gives you some details of the history of how suicide was interpreted or viewed in different times and in different cultures, and I'll let you read that on your own because that's not something that I would hold you to knowing for an exam or anything. It's just to give you a perspective about other times and other thoughts. This slide just emphasizes how prevalent it is and something that we need to take very seriously and understand that it's something that we will probably encounter in our professional practice. More than 38,000 persons in the United States ended their lives in the year for which the latest statistics were available. Third leading cause of death among Americans 15 to 24. Fourth leading cause of death between the ages of 25 to 44. And the eighth leading causes of death between the ages of 45 to 64. So an important cause of death and important epidemiological factors that we need to be aware of. Some risk factors that we should consider in mental health, psychiatric nursing. Suicide rate for single persons is twice that of married persons. Women attempt suicide more often, but men more often succeed at their attempts. And the reason is because men commonly choose more lethal methods than women. So women typically use pills or other non-lethal things that they can be rescued from, whereas men more typically use firearms, things that are more lethal. The risk of suicide increases with age, particularly among men. White men older than 80 are at the greatest risk of all, and they're of all the age, gender, and race groups. And religious affiliation tends to decrease the risk of suicide. Catholics have a lower rate than Protestants or Jews. Just some interesting risk factors there, or statistics. Socioeconomic status. Individuals in the very highest and lowest social classes have higher suicide rates than those in the middle class. Some other risk factors to be aware of. This lists the ethnicity where whites have a higher risk, followed by Native Americans, African Americans, Hispanics, and Asian Americans. And then some other risk factors that we need to consider when we're doing our assessments and our intakes. If they have a history of psychiatric illness, mood and substance use disorders are very commonly associated with suicide, and then other psychiatric disorders that can account for suicidal behavior include schizophrenia, personality disorders, and anxiety disorders. It's a really important thing to note that severe insomnia is associated with an increased risk of suicide. And in the pharmacology class, we talked about the connection between anxiety and insomnia. So that makes sense that extremely anxious behavior could lead to risk of suicide. And again, that link between insomnia and anxiety is very important. Use of alcohol or barbiturates is linked to suicide. Psychoses, when the hallucinations command them to do something and they're commanding them to harm themselves. Affliction with a chronic, painful, or disabling illness causes someone to be at risk for suicide because they want to get relief from their pain or affliction. Family history. People have a tendency, if the family member has committed suicide, they're at higher risk for committing suicide themselves. Homosexual individuals have a higher risk of suicide. About 50% of those who do commit suicide have had a history of a previous attempt, which is very interesting that just having that as a history puts them at a significant risk. Someone who loses a loved one through death or separation, and then lack of employment or increased financial burden also are very high risk factors. So here are some theories about the predisposing factors to suicide. The psychological theories: anger turned inward. Freud believed that suicide was a result of an earlier repressed desire to kill someone else, and that anger was previously directed toward another person was now being turned inward on the self. As far as hopelessness goes, studies indicate that a high correlation between feelings of hopelessness is connected to suicide. desperation and guilt. Desperate feelings often occur when individuals feel the need to change, that they need a change in their life, but they feel helpless to bring about that change. Guilt and self-recrimination are other aspects of desperation, so that's shame and humiliation. History of aggression and violence. Rage and violent behavior have been identified as important psychological factors underlying suicidal behavior. Shame and humiliation. Some individuals view suicide as a face-saving mechanism following a social defeat, such as losing social status or income, something like that. Developmental stressors. Certain life stressors that occur during various developmental levels have been identified as precipitating factors. As far as the sociological theory, Durkheim believed that suicide was correlated to the cohesiveness of a society in which the individual lived. He described 3 social categories of suicide. Egoistic suicide is the response of the individual who feels separate and apart from the mainstream of society, and they have a lack of integration. Altruistic suicide is the opposite of egoistic suicide. Individuals are excessively integrated into the group, and allegiance to the group is so strong that they will sacrifice their own life for the group. Anomic suicide occurs in response to changes in the individual's life that disrupt feelings of relatedness to the group. So the interruption in the customary norms of behavior instills feelings of separateness and fears of being without the support from the group that they felt formerly connected to, the formal cohesive group. And then biological theories. Genetics has shown us that twin studies indicate a possible genetic predisposition towards suicidal behavior. So in other words, if twins were raised in different households or brought up in different households, they still had that there was still a likelihood that if one committed suicide, the other one would too, even if they weren't raised in the same way. And then neurochemical factors. Some studies have revealed decreased levels of serotonin in depressed clients who attempted suicide. So when you're doing an assessment of whether somebody is at risk for suicide, you look at all their demographics, because they were listed on the previous slide, and we talked about how age, gender, ethnicity, marital status, socioeconomic status, how all of those things put or did not put somebody at risk for suicide attempts. And if they have a presenting symptom or a medical psychiatric diagnosis that could put them at risk, whether they do have suicidal ideas or acts, and if they do, how serious is their intent? Do they have a plan? Do they have a means? Are they giving verbal or behavioral clues? Do they have an interpersonal support system? And then we want to analyze the suicidal crisis. What was the precipitating stressor? Do they have a relevant history? Any life stage issues? And then do they have any psychiatric, medical, or family history that puts them at risk? And what coping strategies do they have in place? So again, this slide just goes over the relevant factors that we want to incorporate into our assessment of whether we need to put things into place to prevent suicide. So the nursing diagnoses and the outcomes that might be identified. So the nursing diagnosis for the suicidal client can include either risk for suicide or hopelessness. And if you do have a patient that's been identified as being suicidal and at risk for committing suicide, these are the guidelines for treating that patient on an outpatient basis. The client should never be left alone. They should establish a no suicide contract with the client. So in other words, you write out a contract saying things like that the client will promise to notify somebody before they would act on an intent to commit suicide. You would enlist the help of their family and friends. They would have frequent appointments. The trusting relationship would need to be established. That means that there's been a rapport and trusting relationship already established so that the client would know that they could reach out to you at any time. You would always be direct and talk matter-of-factly about suicide. You would discuss the current crisis situation in their life, identify the areas of self-control, and they might need to be put on antidepressants. And I will stress again, as I did in the pharmacology class, that when some people are put on antidepressants, they are actually at increased risk for suicide until those medications are established and they are at the appropriate medication for them and the appropriate dose, because Sometimes they feel so hopeless they don't have enough energy to be able to act out on a plan to relieve their suffering and anguish, but they get to feeling just a little bit better but not feeling good, and so they are able to fulfill an act that they would otherwise not have had the energy to follow through with. So always be aware with putting somebody on antidepressant medications or adjusting doses or anything like that, that getting on the medication doesn't eliminate the risk, that we have to make sure that we keep monitoring them for risk of suicide. So here's how some crisis counseling would be handled with a suicidal client. You would focus on the current crisis and how it can be alleviated. You would note how they were reacting to the crisis and how you could change how they were reacting to it. You would work toward restoring their sense of self-worth, their status, their morale, and their control over the situation. You would introduce alternatives to suicide. You would help them rehearse more positive ways of thinking. That's called rehearsing cognitive reconstruction. So think of a different way to look at what's going on in their life and help them rehearse looking at it in that positive way. Identify the experiences and actions that can affirm their self-worth and self-efficacy. Help them move toward the new reality and be available for ongoing therapeutic support and growth. So information that we want to provide for the family and friends of the suicidal client: advise them that they should take any hint of suicide seriously, that they should not keep secrets. If somebody says, please don't tell anybody that I'm feeling this sad or hopeless, they can't promise to keep that secret. They need to let people know. It's not something that if they say, I'll get over this, I'm just feeling really, really sad right now, don't tell my mom, don't tell my dad, don't tell my husband, don't tell. That's not something that you agree to. You do not keep secrets. Be a good listener. Express feelings of personal worth to the client. Know about the suicide intervention resources. Make sure that they don't have access to firearms or other means of self-harm. Acknowledge and accept their feelings. Help them attain a feeling of hopefulness. Never leave them alone. Show love and encouragement. Seek professional help, because many family members don't know how to handle this, and they shouldn't try to handle it alone. Remove children from the home. Don't judge or show anger to the person or provoke any guilt in them to try to follow through. So when someone has committed suicide, these are the interventions that could be implemented for the family and friends of the victims of suicide. Encourage the person to talk about it. Don't think that, a lot of times people don't want to discuss that topic because it's uncomfortable. Make sure to discourage any blaming or scapegoating. A lot of times family members will blame each other. Oh, if you had only done this, or you had only been with them, or you had only not said this or that to them. Discourage them from blaming or scapegoating others. Listen to their feelings of guilt and self-persecution, because they all are going to have them and they're going to want to express them. Talk about the personal relationships that they had with the victim. Recognize that people have different styles of grieving. Help them develop their adaptive coping strategies and identify the resources that they can utilize for support. So it's a sad topic, this presentation, but it's one that professionals encounter in their life, their healthcare profession. So let's go on to some questions to practice. A client with a history of suicide attempt has been discharged and is being followed in an outpatient clinic. At this time, what is the most appropriate nursing intervention for this client? Go ahead and pause it and look over the options, and then I'll tell you the answer. The correct answer is D. Assisting the client to develop more effective coping mechanisms is a nursing intervention that can and should be implemented in outpatient settings as ongoing follow-up. The nurse is caring for an actively suicidal client on the psychiatric unit. What is the nurse's priority intervention? Go ahead and pause it. The correct answer is C. Placing the client on suicide precautions with one-on-one observation provides a safe environment for an actively suicidal client. Maintaining client safety should always be a priority nursing intervention. And the last question, which of these options is a misconception about suicide? Go ahead and pause this and consider those potential misconceptions and let me know which one is a misconception. And the correct answer is C. It is a misconception that individuals usually commit suicide by taking an overdose of drugs. Gunshot wounds are the leading cause of death among suicide victims. I hope you found this presentation informative and helpful. Thank you very much for your attention.